All right, I welcome all of you, and again, we're going to be diving into telehealth for our first training of the day. I'd like to begin by offering a poem from one of my favorite poets. Many of you have probably heard of him, David White, and the poem is called "Everything is Waiting for You." So just as an invitation as we enter this topic.
I love this one.
Do you? Good. I know it's one of my favorites. So everything is waiting for you. Your great mistake is to act the drama as if you were alone. Your great mistake is to act the drama as if you were alone. As if life were a progressive and cunning crime, with no witness to the tiny hidden transgressions. To feel abandoned is to deny the intimacy of your surroundings. Surely even you at times have felt the grand array, the swelling presence, and the chorus crowding out your solo voice. You must note the way the soap dish enables you, or the window latch grants you freedom. Alertness is the hidden discipline of familiarity. Alertness is the hidden discipline of familiarity. The stairs are your mentor of things to come. The doors have always been there to frighten you and invite you. And the tiny speaker in the phone is your dream ladder to divinity. Put down the weight of your aloneness and ease into the conversation. The kettle is singing even as it pours you a drink. The cooking pots have left their arrogant aloofness and have seen the good in you at last. All of the birds and creatures of the world are unutterably themselves. Everything, everything, everything is waiting for you. So I offer that poem as we open to a conversation about telehealth, because there's something about this space that opens us up to everything, to things that are imaginable and unimaginable, and also offers us an opportunity to sharpen faculties within ourselves that towards a particular type of alertness, because we're missing so much and yet we've got so much in front of us. So I just offer that as an invitation, kind of like planting a seed of the intention of how I want to hold this space actually the whole day with you today, sort of a poetic embrace to see if we might, learn something new or find a different approach. So with that, I'm going to share my screen. And as we move along, if you have thoughts or questions, by all means, please go ahead and put in the chat. I'll try to keep my eye there as well. Okay, let's see here. Hopefully this works. Okay. Can you all see my screen? Regan, I see you. Can you see, can you see my screen okay?
Yes.
Yeah, awesome. Thank you. Let me close this out a little bit. Okay, and if I could just get rid of this a little bit, that would be amazing. Okay, so telehealth as psychological. Well, first of all, I'm going to be taking this topic and I'm going to dive into kind of depth psychological perspectives. I have a sense that you all know what I mean by this, but just to clarify where I'm coming from. My doctorate degree is with an emphasis in depth psychology, which means leaning into the unconscious. And this sort of is an umbrella for psychodynamic, psychoanalytic oriented work. And I thought it would be really interesting to take telehealth and to explore it from this perspective. So that's my intention. with that, we might understand telehealth as a psychological space. This is what I'm most interested in. How is it psychological? We can start imagining it's not simply a technological medium. It can be looked at as a threshold space, sort of a liminal field where two or more subjectivities meet. And we're meeting across distance, light, and screen. I mean, I'm sure that each of us right now are coming from different places in California, maybe even outside of the state. Um, so it's interesting to start thinking about how we can share this threshold space psychologically. So our consulting room in person sort of dissolves into pixels, but the relational field remains. And presence becomes mediated through this field. The containment shifts, and then the analytic frame must also be reimagined. I'm hoping we can do a little bit of that today. We'll be talking about this a little bit later. Transference, countertransference, of course, still emerges. Silence still speaks, and the unconscious finds new forms through which to move. So, from a depth-oriented perspective, we're invited to ask, what happens to psyche when the room becomes virtual? And how do we hold depth within this altered field? From my perspective, there is great value in looking at telehealth through the depth lens. We see telehealth is not neutral. It's actually quite structured by law. It's shaped by technology, and it influences relational dynamics. It also alters embodiment and the spatial experience. To practice responsibly in California, we must hold both the regulatory frame and think about the psychological field. So the value that the depth perspective offers us is that it invites a very deep, reflective curiosity. It doesn't ask us just to simply adapt to this new way of being. It invites us to drop into it and to ask, what more can we see? What more can we hear? What more can we feel that perhaps we can't see and feel when we're in person, which is kind of interesting. So my intentions for today are, as I've noted, to dive deeper into an exploration of telehealth from a depth psychological perspective. We do want to try to understand the legal and ethical requirements as per the BBS and CAMP, so we will be going over those. We're going to be examining how the therapeutic frame, presence, and unconscious processes shift in virtual space, and ultimately to think about cultivating thoughtful, ethically grounded telehealth practice that's anchored in our clinical sensibility as well. So telehealth in contemporary clinical practice. So as we all know, since COVID, essentially, telehealth has now become a standard or modality of care. I would say most of my colleagues that have private practices, most of them are completely telehealth. I'm also in private practice, and I'm noticing a trend in my own work. There are folks that want to be in person, but telehealth has just opened up a whole nother world we'll talk about more. California law does regulate its delivery, and competence in telehealth is required for licensure. I believe BBS requires 3 hours of training. And as Dr. Marlowe noted, this training will be counting towards that, which is great. Our ethical responsibility extends fully into the digital space. We'll be talking about what that means. And also, I'm hoping to tease apart ethical/legal responsibility versus our ethos, which is a more general way of how do we show up in the space, regardless of digital or in person. And telehealth is not an exception to practice for many clinicians. It is practice. So this idea of holding two frames, from a psychodynamic perspective, and practicing in California, there are two frames that we're being asked to hold at the same time. One is a legal frame. So this covers licensure, appropriateness, meaning is treatment via telehealth appropriate clinically, informed consent, documentation, emergency planning, and more, which we'll cover in detail in a second here. But there's also the psychological frame that we don't always talk about that is just as, if not more important. So this includes transference, countertransference, containment, presence, symbolic process, and the idea of how the work lives within the tension between structure and soul. So it's those two frames, and I'm inviting you to see if you can find the tension between those two and see if we can hold the tension of these, because oftentimes they can feel as quite opposite. My goal today is to see if we can integrate the two because they're both present at the same time. So here we are. Let's do kind of a live reflection. We're already in the field here today. I'm wondering if before we can dive in, if we can just notice that we're already practicing something. So this is really just a brief invitation to pause and look at the screen. Self-reflections, I'm inviting. And we'll take just a few minutes. What is your felt sense of being here in this digital room? Where do you experience connection? Where do you experience distance? What parts of you feel present? What parts feel muted or absent? How does the grid of faces affect your sense of relational space? How does it feel when folks are off camera and there isn't a human there, but perhaps a name or an image? What comes up for you with that? How does that feel? What is psychologically different for you from sitting in a physical classroom? And then from your perspective, is the screen in front of you a window? Is it a mirror? Is it a veil? Is it a portal? And what does it feel like psychologically to meet through that window, mirror, veil, or portal? I thought if we could just take just a few minutes to self-reflect, maybe choose one of these, and see if you can answer it for yourself. So let's just take just a couple minutes to explore this just individually for now. Another minute or so. Also thinking about what does it feel for you to be in the space and the screen being occupied by a PowerPoint, maybe not being able to see everyone's face. And we'll get to explore this together in breakout rooms in just a little bit. Somebody. Okay. So take those reflections, take these questions, see if you can put them in your heart and hold on to them. Um, these are all questions that can actually inform the clinical work we do. And they're actually, excuse me, they're actually questions that you might even be able to use with your clients to start the conversation about the relational field. What does it mean for us to show up in this way? So holding on to that. How do we hold on to the tension of the two realities? So asking ourselves those questions and everything that we're experiencing in real time right now is actually not abstract. There is a clinical reality to what we're experiencing right now through our connection, disconnection, whatever is coming up for us. So this digital medium shapes presence. It shapes projection, it shapes containment, and it shapes relational space. It doesn't take these things away, but it's, I guess, feels important to just think about how it impacts, reshapes, or I always like to hyphenate these words, recognizes, rethinks, makes us rethink so that we might be able to see something more. Because it shapes the psychological field, inevitably it shapes our work. And because it shapes our work, that's the link where it starts to become ethically and legally regulated. That's where these two worlds come together. The real world with what we're bound to in terms of ethics and legalities, and that deeper, more soul, unconscious space. So we're going to start moving into some California guidelines just to cover. But as we do, I really invite you to think about holding the psychological field um, and, and to start putting together how the regulatory structure contains that psychological field. So from a psychodynamic perspective, the legal frame becomes our container. If telehealth is a psychological field, or if it includes a psychological field, then California law and all of the regulations become part of the frame that holds it together. The BBS and CAMPT do not regulate technology alone, but they do regulate how people, how we hold people when the room becomes virtual. And this is really important for us to understand. So now we see it's not just about adhering to laws for the purpose of adhering to the law. From a psychodynamic perspective, we're understanding I'm using the law, I'm leveraging the law and ethics that have been put in place in order for me to create a frame that allows me and the client to dive into the work. And this is deeply psychological because if there isn't something that's holding us, and if I can't communicate that through my ethos, the way that I'm showing up, the unconscious is going to stay hidden. And from a depth perspective, part of my work is to bring to consciousness what is unconscious. And if there isn't safety and security, that's not going to happen because the defenses will be too strong. So I'm just trying to orient us and sort of connect and rethink and reframe what the laws mean, because the laws and the paperwork and the hours and the forms and all that stuff tends to create some particular experiences in our brains as therapists. And so I'm hoping to kind of reframe that and see how we can leverage it. So again, from this psychodynamic lens, law functions as a structure, and structure in depth work is containment. So this type of structure, the law, is not the opposite of depth. It's what makes depth work possible. Why and how so? Because we believe in the unconscious. If you're working psychodynamically, psychoanalytically, any depth-oriented perspective, we believe in the unconscious. And the unconscious only comes up if there's safety, and that happens through containment. So again, just kind of connecting those dots and putting it into perspective. So part of this is thinking about presence and place. Place matters. The therapy room has never really been neutral. It always holds, it contains, and it offers a physical marking of the boundaries of the analytic field. You walk into the office, there's a door that opens, there's a door that closes. I know my private practice in person, there's a waiting room, there's a whole ritual of events that happens. My patients come into the building, they walk up the stairs, they find my office suite, they open that door closes, they're in the waiting room, they're waiting there, then that door opens, they're invited back, that door closes, then my office door is open, they're invited into the space. I mean, think about all of the different various layers of frame and boundaries opening and closing and crossing over that happens when we're in person, and how that shifts when we're here on Zoom. It may not always shift as much as we think, but there's definitely a shifting. So in telehealth, that physical space of our office may dissolve, but the notion and essence of place does not disappear. There's a psychological place that remains present. And that's important for us to understand because that helps us hold the space with that knowing, with that understanding. The client is somewhere, we are somewhere, and California law offering us structure and containment recognizes this reality. This is where the two places come together. So in telehealth, practice is considered to occur where the client is physically located. In this way, presence is mediated, but the place remains legally and psychologically real. Even in digital space, we're always practicing somewhere. I don't know if this is a new. Yes, we will get a copy. I will give, we'll post a copy of the PowerPoint, so don't worry of taking notes. In fact, I would invite you to perhaps not take notes. Let yourself doodle, let yourself be here and just soak it up, and I'll send it all over to you. Thank you for that. So in digital space, we're always practicing somewhere. This leads us to licensure and jurisdiction. So if telehealth is meeting across distance, the law is asking one simple question. Where is the client? This is most important. Where is the client? In California, telehealth is legally considered to occur where the client is physically located at the time of service. This means that even as trainees or associates, and once we're licensed, we're participating in regulated clinical practice. Practice is legally considered, again, I'm saying it over and over again because this can get confusing, where the client is physically located. Those of you who are being supervised, your supervisor must hold an active California license if you're in California, practicing in California, if the client is in California. And you may only provide services within the legal scope of your registration and supervision agreement. If a client is physically in another state, services may not be permitted even under supervision, because jurisdiction follows the client's body, not the therapist's screen. Though you practice under another's license, you're still responsible for knowing the frame that holds your work. This is a really important piece. And especially as you are finding your voice as a clinician while you're being supervised, oftentimes that, while we're training, we do lean into the protection of our supervisor and our school and all of the people that are mentoring. But this is the time where we start really finding our own clinical authority and knowing, and really understanding the frame. And the frame meaning not only the psychological frame, but also the legal ethical frame. Supervision does not remove responsibility, it just deepens it. So any questions around this topic, I always, all questions, I always invite people, get supervision around it, seek consultation, go to the BBS, connect with CAMPT. There's so much information. And one thing I always appreciate about the law is that it's easy, it's just there. And it gives us what we can do and what we can't do. And any gray area, we can always look into and explore and find answers to. So in 2025, just something to note, there was a change of law in terms of displaying our license. So effective as of January 1st, 2025, licensees and when you're registered, only required to display your license or registration when rendering professional clinical services in person. So license and registration does not need to physically be on display when services are provided via telehealth. However, this must be included in the notice to clients. And I'll also offer, I'm going to send this to you, but you'll be able to get those resources as well to get more information. So before we get into telehealth with clients, one of our clinical sensibility and the psychological framework is assessing the appropriateness. So just because telehealth is there as an option, it's not always appropriate for every individual, every one of our clients. So under BBS and CAMPT, the BBS regulations and ethical guidance, we are responsible for determining whether telehealth is clinically suitable for each of our clients and for reassessing the suitability as treatment unfolds and for documenting it. I include this documentation in each of my clinical notes. After every session, I use the same language that the client was deemed appropriate for telehealth. So here's some considerations. We want to look for the level of acuity and risk. In other words, how urgent or high risk is this situation right now? We want to look for any kind of suicidal, self-harm, homicidal ideation. We want to think about domestic violence or unsafe living environments. Is it safe for the individual to do telehealth from home? This is also super important when we're working with kids and minors, because they may not be able to speak freely when they're at home if something is happening in the home. So that takes on a whole nother layer of considerations. The client's ability to secure privacy, cognitive, developmental, or technological limitations. There are some individuals that this format is just not going to work for one reason or another. The impact of the medium, meaning the telehealth virtual space, on clinical depth. Is it appropriate? Can we get there? Would we be able to do better work in person? If that's the case, we would have to recommend in person. So again, for trainees, these decisions are not made alone. It does belong in supervision. And I'm hoping that for those of you that do work via telehealth, that your supervision conversations might open up if they're not already in that space of the psychological piece. I'm hoping that after today, you can really open that up and start thinking about what does a space mean, not just technologically, but also what is that psychological piece? What is going on? Working from a depth perspective in telehealth asks the question of, does this format support the work of this person at this time? That's the question we want to think about. That's the question we would bring to supervision. And I would invite all of you, sometimes at the first glimpse we say, oh yeah, definitely this works. It's always meaningful to take a minute, reflect on it, journal it, walk it, consult about it, especially in the situations where it feels like an easy, for sure, this is great. There might be something underneath it that hasn't been seen yet. So our clinical judgment around assessing the appropriateness in telehealth is part of our ethical practice. And our ethical practice is part of legal compliance. And legal compliance is part of our ethos. So remember, ethos is really about the way that we are showing up, our individual integrity of how we're showing up. So this is how it all comes together. Once we determine that telehealth is appropriate, that discernment must be reflected in the record. So as per BBS guidelines, you want your documentation to include confirmation of the client's location at the time of session, assessment of continued appropriateness of telehealth, any identified risks and how they're being managed, crisis planning when relevant, consultation with supervisor when indicated, and for documentation, something to bear in mind and to think about. Documentation is not defensive writing, right? It's being clinically transparent, and it's also owning my authority as a clinician. This is the great opportunity that you all have as you're continuing to learn and strengthening your voice as a clinician. Um, Filling out documentation, including all of this in your notes, that is you strengthening your clinical stance and your voice. Documentation tells the story of your thinking and your intentionality, specifically when it comes to telehealth. You're documenting to share your intentions about why you're choosing telehealth. So this is not just a random, I do this with everyone. This is really you taking the time, assessing, documenting, and showing up in that with that ethical stance. While we're training, documentation, well, and beyond training, documentation protects the client, it protects you, it protects your supervisor, and it protects, I guess, the whole field, right? How psychotherapy is seen in the world, and how we're holding it in the larger individual and collective sphere. So the documentation here of what I have included, again, it is recommended that every note that you write when you're doing telehealth, you're including all of these elements. And clarity in this record really reflects clarity in the frame. Again, even though, we talk about the frame as this physical space with the client, Notes and the way that you're holding that piece in the documentation is also part of the frame psychologically. From a psychodynamic perspective, we're holding psychological space of the client. So if I have a client session and I'm really there and I'm doing great work, and then I don't document the session or I delay to document the session, I've just leaked the frame. I've just broken the frame. There's something psychological about taking the moment and time to think clearly and to do those notes. So the notes become more than just something we have to do. It becomes part of the work. It's where I get to document and honor what just happened. It's an honoring of the work that we did together. That's the way I like to think about it, to add the depth to these parts of our job that can feel taxing and mundane and like, oh, I just, I'm too much on the notes. I just want to be in the work with the client. The notes hold a lot of psychological weight in the frame. And kind of reframing and rethinking how we're holding all of those pieces. So beginning each session, telehealth, how do we ground in place? Um, we cannot assume the location, right? So we have to ask and we have to document that ask. So each session, I'm coming into the session, we get into a place where we recognize where the client is. And so you may not, you may get to the place of, okay, I know this is the living room of that place. I recognize it. But if not, I'm asking, oh, so where are you today? Um, and it might be a location in California that maybe client is visiting family, or maybe they drove down south. They're still in California. So I would also ask for the address if they're not at the location that I know. Um, so again, at the beginning of the session, we want to confirm the client's full name. Again, once we know the client and we're in the work, we know this piece. We want to confirm the physical location, and we want to assess whether telehealth is clinically appropriate still. And again, I apologize for the repeat, but we're documenting, documenting, documenting. I actually have a kind of script that I have. And if it still fits, I will put it in there in every note that this is what I did, this is where they were. Yes, the client remains clinically, telehealth remains clinically appropriate for this client. So this is not mere procedure. Again, this is where I want to connect the dots between that psychological depth place and our ethical stance. It's an acknowledgement that therapy happens in a real place with real safety implications. And if a crisis emerges, we have to know where the person is. That is part of our requirement ethically. So although the digital field is more fluid, safety remains concrete. And by us asking these questions, we're also communicating to the client and to the client's unconscious that we are tracking, that we are creating a safe container. I know where you are. We're in this together. And if something happens, I know what to do to find you. So the ask here is noticing how this intersects psychologically. We're orienting to the body in space, even when the room is virtual. I want to speak just a little bit about containment and crisis. So when we're in person, containment is partly architectural, meaning we're in the space. We have walls and the space protects. In telehealth, containment has to be a little bit more intentional. And part of that intentionality does include, that's me asking, where are you? Do I have the right address? Do I know where is the closest hospital to you? I mean, I've got lots of patients who perhaps are down south in California, and I have on record when I'm on in the session, I've got their file pulled up in the next tab. And if I need to call them or access an emergency location, I've got that information of where they are. So it's important to obtain and document this emergency contact information, and especially when we're working virtually, to have it handy. So you want to identify local emergency resources in the client's area and also develop a crisis or safety plan if that's clinically indicated. Again, this is not something at this point that you have to do alone, and I'm sure you've all done this. Consulting with your supervisor, especially when risk emerges. And again, documenting actions carefully. If a rupture occurs in digital space, we can't rely on proximity. We have to be prepared. So oftentimes before starting the session, well, I might say something like, if we get disconnected or sometimes the connection is not good, I've got the client's phone number and I say, if we get disconnected, I can't reach you, I will call you. So again, that's me doing my best, hopefully, to communicate to the client and their unconscious that we will remain connected one way or another, so that we can ease into the work. So again, containment in telehealth is not assumed the way it is in person, right? Because remember that whole process of getting into the office, it's sort of assumed we're in this space together. You're in that chair, I'm in this chair. Same walls, same windows, same decoration. But with telehealth, we have to construct that a little bit more intentionally. So in depth work, we speak of holding the psyche. And in telehealth, we must also be prepared to hold the body in crisis across distance. And we do that by preparing the best we can. I want to speak just a tad to the analytic frame in digital space. When we speak of the analytic frame, when it comes to psychodynamic perspectives, this is really speaking to the structure, the boundaries, the rhythm of the work, the expectations, time. When do we start? When do we end? Disclosures, payment, confidentiality, clarifying roles, and consistency. So all of these are silent and not so silent ways that we create the frame. In telehealth, the visible room sort of disappears, or I should say the shared visible room disappears, but the frame doesn't. We understand that there's still a frame. It becomes more subtle in some ways, and it can become more fragile in other ways because the client is in their space and we're in our space, and the field can stretch across distance. So this requires some greater intentionality. So we have to really work at setting clear boundaries around time and privacy. Being very thoughtful of management of disruptions. We want to be having explicit agreements about space and confidentiality, and consultation when the frame feels strained. So for example, when the client comes on, are they wearing AirPods or headset? Are we wearing a headset? What is the implication around that? When I notice that my clients are not wearing a headset, I'm constantly having to wonder, is it possible that someone might be hearing me speak to them? And what does that mean? And the same might be true the reverse. If I am not wearing my headset, I can imagine, part of my ethos is to imagine how that must be for the client, especially if I'm here in my home. And whether or not they're consciously aware, how does that translate to their psyche? Are they wondering if someone is listening to them? Are they wondering if someone else outside of my office might be hearing? Um, these are all just questions and things to think about. And if anything, aside from right or wrong answers, the depth perspective, psychodynamic, psychoanalytic stance really asks us to think about these things, as opposed to just doing without thinking. So it's not necessarily a right or wrong here. It's really about just thinking deeply about these things and how they might be impacting the space. Um, so the screen mediates the session, but the frame still holds if we hold it. So oftentimes clients will say, can we still do meaningful work via telehealth? And my thought is absolutely. But then I understand absolutely, as long as I am able to hold the frame in a way that can allow the work to open. Let me see if this is a question that. Oh, great question, Ashley. How would you approach the client not having their camera on and denying not turning it on? Well, such a great question. And that would be a conversation I would want to know more. I would want to know more. And I'd also want to know, um, if the expectation is for me to have the camera on. And that's perfectly okay too, if they want to have the camera off. I mean, I think I would just be really curious around what that means for them. And I would hope that we could talk about that. I mean, I would just be really curious about what is that for the client? Are they not having a good day? Are they not wanting to be seen? What is happening in real time? Because the telehealth also translates into phone calls. I mean, we've got some individuals that don't have access to computers and such, and so we have a phone call. Um, so I think you know, I always get frustrated with this, but the most common answer, as we know, psychology is it depends. So it really depends on the client, what's happening, what the presentations are there any risk factors? I mean, if it's really high risk and I'm not feeling like this is a safe space, with that camera off and something's going on, I might suggest a different thing for that session. Um, Oh, interesting, Lisa. Would you ever want a client to send them or to send a screenshot of their pinned location to verify sending it to me? Thank you, Ashley. I have not required clients to send me that type of proof, but what I do is I document that I asked the client where they were and they confirmed that they were at their home address, and I've got that home address in the file. Or they confirmed that they were on vacation in Southern California at their mother's house and they gave me the address or whatever the case would be. Um, so that's how I hold that. And that documentation is the thing that holds it secure. Uh, yeah, I hope that helps. Yeah, yeah. So this is where documenting becomes really important, right? And the truth, look, with telehealth, right? I know. I'm in the East Bay right now. I'm in San Ramon, but for all I could be in Greece, right? Like how do we ever know? My due diligence as a clinician is to follow my regulations the best that I can and to communicate through documentation my clinical sensibility and thinking. If I don't ask, if I don't document, and then somewhere down the line something happens and it comes out that the client really was in Greece and, God forbid something happened, that's where I'm going to have a hard time. Um, yeah. This is all my own therapist says if we are not in person, phone only. Uh-huh. Yeah. And thanks for pointing out the phone calls are also, yes, yes, phone calls for so many of our clients, right, that cannot access the computer or don't have a computer for various reasons. Um, so you can certainly do phone. And again, I still ask, where are you located? And do you feel like you're okay to speak freely? Um, so I do ask those questions, and then I document that I asked the questions, and I document how the client responded, what they confirmed. Um, okay, hold on. Leslie, sorry, maybe you mentioned this earlier, but what can we see our clients on tele if they're in California, but we're out of town? You mentioned the license is not based on our location, but our client's location. Yes. So here's the thing. Before you are out of town and you see a client, I mean, it is based on where the client is located, but I would also check in with your supervisor. Like if you're going to be out of the country, for example, and you're seeing your clients in California, I would just check in with your supervisor around that because especially if you're working under someone's license, they might get particular about this. So I would 100% check in on this just to confirm. We're licensed therapists in California. Clients must be in California, but we can be anywhere. Yes, that is the general rule. And while you are being supervised, I would just make sure that everyone's on the same page. Oh, yeah. Yeah, thank you. Such good questions. And again, much of our clinical sensibility and ethical sensibility is about thinking through things, asking the questions. We don't always have to know exactly the answer, but asking the question and doing the research and getting the consultation and getting the supervision, that is our ethos. That is what we want. I mean, oftentimes I'll have questions and I'm like, oh, I don't know. I don't recall. And I go back and I look. So it's okay to not know, but it's not okay to not look into it and learn, if that makes sense. Um, okay. So the work is allowed to deepen because the frame is stable. That's the most important piece. Yeah, thank you, Leslie. That's the most important piece about the frame. I want to talk just briefly about transference, countertransference. Um, so interestingly enough, the screen does not eliminate transference, but it can reshape it. Um, projection still moves, but now in a different way. Clients may experience us as closer or more distant, less powerful, more intrusive, less intrusive, easier to idealize, easier to dismiss. And then this space becomes part of the relational field itself. I mean, I'm sure for those of you who engage in telehealth, you know we are now in the bedroom and sometimes in the bed of the clients where they show up dressed a certain way. There's animals in the field, children come into the fields, partners come into the field. We see backdrops and decoration. Um, oftentimes, in their home, they'll show us, oh, look, here's that beautiful thing I wanted to show you, and they'll bring things into the screen. So um, the transference countertransference is 100% still there, active and alive. Um, okay, I just want to make sure I didn't miss something. Maybe I did. If I did, please bring it to my attention. So as clinicians, we might notice a heightened self-consciousness. We might notice a different type of fatigue or a different quality of attunement. Here's that question. Let's see. Oh, no. Oh. think there's, okay. Our awareness of ourselves as images can subtly shift authority or presence or embodiment. We will talk about that word authority. I know that in our field, and for those of us that come into the field, power, authority, these words tend to be taken with a particular heart. But it's important for us to recognize that there is an authority. Folks are coming in seeking our help, our guidance. They're paying us oftentimes. Um, so what does it mean if I show up at home? And what does it mean how I show up? These are things, again, not necessarily rights and wrongs, but things for us to think about. What does it mean when I show up with my background blurred? What does it mean when I show up and it's not blurred? What does it mean? What could it possibly mean? What am I giving to the patient? Depending on how I'm dressed, if I hold the same standard as I do when I'm in the office. So countertransference might feel more cognitive, less somatic, and at times more ambiguous, or it might even be more somatic and less ambiguous. So it's definitely still in the field. So telehealth can ask us to recognize that we're working within a technologically mediated field that shapes how unconscious material emerges and is experienced. But I think what's most important is that because there's still a relational field happening, that unconscious material is 100% still in our midst. And that feels important to bear in mind. Oh, such a great question, Victoria. Yeah, how do we deal with sudden situations? Everyone's at home, partner, kids. Can we still conduct a session if the client is okay with it? They're in the room with their partner. Um, I mean, that's a tough one, right? Because, and it really depends on the client and the situation and what they're coming in for, because oftentimes it could be an unconscious test. Are you capable of protecting me? Are you capable of securing the space? And that's the unconscious questioning that the client might be bringing in. Consciously, many of our clients don't think about these things. They're like, well, I already just told my spouse or my partner all of the stuff I'm telling you, so it's okay if they're listening. Or my child is just 8 months old, so they don't understand anything about the feelings I'm expressing to you. But coming from a depth perspective, we have a different take. I definitely have a different take. There's a particular psychological, emotional energy that's coming out through the field. We felt it earlier. Remember when we stopped the conversation about graduation and all of this stuff? Remember the feeling in the space? There was a feeling. I could feel it. It was a little bit, I don't know what this means, but it was kind of like a sobering, more serious. I don't know if there was some anxiety. We had talked a little bit about the political nature of the world. So you can feel it. Now, if a client has their little one there, we know that little one is going to feel it. So these are conversations that we can do, we can have with our clients, psycho educating them while at the same time securing the space and communicating to them and to their unconscious that we're securing this. So how would I handle it? I would say it looks like you've got family there. Do you feel comfortable speaking? And they'll say, oh yeah, I do. And I'll say, is there another location in the room where you might be able to go so that we can just really secure our space? Because there's something about what we're doing here, that even though they know the story and they've heard it and you're not hiding anything, I'm wondering what this does to our relationship when other people are involved. So I would psychoeducate from that perspective, and I would share with them how I hold the space. Um, yeah, if you're treating the individual, are they getting their needs met the same way with other elements? Exactly. This is at the foundation of our clinical sensibility. Like if I'm treating the individual, what does it mean for the treatment if they've got people walking in and out? I mean, think about that just in terms of the sacred space. My thought process, for whatever it's worth, and I think of that with us right now, this is a sacred space. We are creating a space together. We are setting the tone together, literally right now. We are setting the tone of if this space is safe, if we can play here, if we can learn, if we can not know, if we can say we don't know, if we can learn, know, we're doing that together. So what does it mean? What would it be like if my family members kept coming in and out? And I was still able to do this, but what would it mean if doors were opening and closing? What happens psychologically to the field? Again, our clients and the world outside of this field, psychology field, may not understand this piece. Um, that's why we're going to school to learn about this. That's why we've got the law and ethics. That's why we're taking these courses. There's something about this work that is more than just talking to people and listening to the story and holding and being present and bearing witness. There's a psychological dynamic happening. So I hope that was a long answer to your question, but I hope that at least offers some type of orienting. Again, there isn't necessarily a right or wrong, but what I'm hoping that you walk away with today is just the mindful understanding to think about it. What does it mean if I don't ask them to find a safe space? What am I communicating to them? Um, and how is that going to impact the work? Yeah. Thank you. Those are such great, 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 great questions. Um, so again, it's not about if depth happens online, but how it moves differently. Just a couple more slides and then perhaps we can take a lunch break. But there's a certain listening with a different ear and seeing with a different eye that we're invited to do. So it really, telehealth does offer us the ability to refine our clinical instruments, those faculties. We can't really rely on the full body in the room, and we don't receive the same somatic field. So our peripheral awareness narrows, silence feels different, the rhythm of the interaction shifts. So it really does call for a different listening, a different seeing, and a different being. Um, we might notice when the voice tightens, when it flattens, when it becomes distant, um, or carries unspoken affect. We're really tuning into the pauses, to the shifts. When does the client look away? When do they when do they get lost in reverie, perhaps? When do we look away? When do we get lost in reverie? These are all things that we can start to understand and learn, and they're just faculties to strengthen our clinical sensibility. So seeing with a different eye, what I mean by this is, again, noticing those micro expressions. The client's background, we look at that. What is shown? What is being withheld? What carries meaning? Where do they show up? What room do they choose? What are they wearing? How are they showing up? All of it not necessarily means something, but I'm recording everything and I'm holding it with respect and curiosity of how, how is this informing our psychological field together? So telehealth is really asking for greater precision. We're not listening less. We're just listening differently. We're not seeing less. We're seeing through a mediated lens and learning how to interpret what the lens reveals and also what it conceals. I'm going to go over just a few technical and clinical issues. So the technical considerations, again, internet stability, platform reliability. We want to think about HIPAA compliant platforms. We want to be documenting all of that. We want to think about audio delays, frozen screens, dropped connections, all of which I love, by the way, because I use it. I use it to inform the work. I'll talk more about that. Camera placement, lighting, sound quality, backup communication plans, also HIPAA compliant protection of electronic records and session data. And then clinical issues, disruptions, um, heightened self-consciousness due to on-screen visibility. You know, sometimes we get on Zoom and we can see ourselves. What does that mean? Like, we're doing a session and like client is there, but then I'm also there. And then sometimes I can't make me go away. And so it's curious to think about how is that impacting me, watching me while I'm trying to focus on the other. Um, a Zoom persona. Yeah, the Zoom persona. That's the other thing. What is your Zoom persona and what is that all about? Um, Difficulty assessing nonverbal cues. All of these are some clinical issues. Managing silence. What does the silence mean? How can I trust the silence without, or like hold it or cultivate it without fearing that it's going to diminish the work, you know? Yeah, taking pauses and offering space and holding the way that we lean in or lean out. All of these are things to think about. Navigating sessions when privacy is compromised, like we said. Um, as we go on for the rest of the day, what a great opportunity. I mean, to learn about ourselves. We're literally doing it all day today. So just an invitation to notice your own image on the screen. Um, Notice where your eyes rest. Notice what you feel when someone looks directly into their camera. Notice how you feel when you look directly into the camera and what happens, what gets lost, what gets found. Noticing your body, your posture, your breath, a subtle tension. Noticing who feels closer and who feels farther and why. And then, yeah, observing and what happens when we don't talk. Um, just observing. I invite you to, if you can hold this in your consciousness and awareness for the whole day, especially when we dive into the diversity discussions, this will be a big one as our heart and our mind gets activated in that conversation. And then asking and reflecting, did you feel more exposed or more protected than in a physical room? Anyone feel idolized, invisible, flattened, or intensified? And how might these dynamics show up in therapy? Yeah, I'm thinking about the poem by David White, Everything is Waiting for You, and great mistake is to act as if we're alone. What does it mean when a client feels deeply alone in this space? Is that informing us of something of a deeper thread? Again, these are all questions and ways to bring the space alive and to think about it clinically. Yeah, I like how that came up last. Okay, so holding the clinical center. We've talked a lot about this. So, um, yeah, clients do see into our homes. What the heck does that mean? Clients will come and they'll show up. Now, once they know me, they know, but oftentimes the first question is, "Oh, are you in an office or are you at home?" What does it mean when I say, "Yes, I'm at home"? What does that mean psychologically, this boundary? They see into our homes. I am in my home. This is my home office. It wasn't set up for telehealth. It's just my home office. So what does that mean? That people get to see into maybe some books that I'm interested in, or maybe some knickknacks that were given to me as a gift or part of my cultural identity. So we see into their homes, they see into ours. Um, yes, yes, we notice everything. So thinking about that as well, and what does it mean when yeah, how do we craft that space? Again, more so than right or wrong, it's about being thoughtful and intentional. Um, So for practice, we want to be intentional about our visual presence, the camera angle, our posture, the eye contact. Um, what happens when notifications come in? One time I had my my email open in another tab and I'm on Zoom and bing, and so then my attention gets distracted and what does that mean? Those subtle shifts, or when a phone call comes in and there's a little bit of a bump, how can we understand that? Um, Doing the best we can to be clear and steady with structure, time boundaries, session openings and closings, payment policies, and such. And then, of course, bringing all of the feelings and experiences into supervision. I hope you're all really leaning into your supervision moments and consultation and getting the most out of that. Um, we had a little bit of this conversation already about privacy, something that we need to talk about and think about. So, privacy and the unseen other, what does it mean? Who might overhear? Who's going to walk in the door? We can't control the environment in the same way. What's my relationship to controlling the environment as a therapist? That's another thing. Um, yeah. So depth work really invites us to consider what shifts when the unconscious knows or suspects that someone might be listening. What shifts in me? I mean, I know personally as a clinician, I'm when I'm being I don't know if we're being recorded, but something happens when someone's watching, and we have to be mindful. How does confidentiality shape regression, disclosure, and vulnerability? These are all really important things to bear in mind with telehealth. And most importantly, privacy is psychological and it's practical. So how do we protect the frame? Again, we've talked about this. I'm repeating it just because of how important it is. You just want to express everything, get everything in writing, and document, document, document. Um, Standard of care, this is also a piece that we are assessing. There are guidelines under BBS regulation and then CAMPT ethical guidelines. We need to practice within our scope of competence, and especially via telehealth. If we happen to be certified in a particular way of treatment and that does not do well with telehealth, we have to be mindful of that. Um, Maintaining confidentiality, assessing again the appropriateness, and providing appropriate referrals when telehealth is not sufficient. Can't say documentation enough. Um, and our ethical obligation always stays the same. And again, as long as we have that strong ethos, which is not exactly ethical in terms of the law, but just my general way of how I show up. Um, that helps. I think this is our last slide, just a bit on cultural competence. So telehealth can absolutely amplify culture. Again, we're really seeing clients enter sessions within their lived environments, whatever that means. Um, Family, class, religion, language, geography, and access. The background becomes visible, privacy varies, technology access is not equal. That's something for us to bear in mind. So, things to consider: access to reliable internet, economic disparities that shape resources, immigration status, concerns about surveillance, multi-generational households and shared lived environments, disability accommodations, accessibility needs, language differences, interpretation over digital platforms. Um, the digital divide is really not abstract, it's actually quite structural, and that's something for us to bear in mind. And under BBS standards of care, competence really includes recognizing how cultural, socioeconomic, systemic factors affect access, privacy, and safety in telehealth. And then the question is, how do we hold that? What do we do with it? How can we bring it into our clinical sensibility? Um, from a depth perspective, this asks us to remain deeply curious about how identity and context shape the experience of meeting through a screen. Um, and the question that we're asked to hold is, whose space are we entering? And how does that space shape what can and cannot be spoken? And how are those things spoken and kept in silence? We'll talk a lot more about this in our diversity section. So the end of I'm going to stop. I'm going to stop share before we go, as we prepare to go to lunch. But I had left, and you'll see this vignette. I had offered a vignette about the frozen screen, and I just want to share just a tad about how I approach those situations. Um, I've had multiple situations, as I'm sure all of you have as well, those of you that, where the connection fails just at that moment, right? Like just at the moment that we're talking about the thing that we've been needing to talk about, or the thing that keeps happening, all of a sudden it just goes down. And then we have to both struggle to reach it. So the way that I hold that, after I go through my anxiety of like, oh my gosh, what just happened? And did I let them down? And I kind of step outside of myself a little bit. And I use it as a way to have the conversation. What does it feel like to be disconnected from self and other? What came up for you? Oftentimes, that's a beautiful experience to have the client really dive in and say, I was so angry that I really wanted to tell you this and I was so angry. Well, guess what? Now we have anger in the space. Beautiful. Or they say, I was so afraid. I didn't know if I was going to find you again. Beautiful. Now we have anxiety and fear of disconnection. We have something to talk about. So I use it clinically. Whatever happens, I use it clinically. And the more I lean into this way of doing the work, the more synchronicity comes in and things happen just at the time. And we're able to say, wow, how curious that that happened just as we were talking about this. And it brings sort of this sobering dropping down into the conversation, which really deepens the work. So I hope that we get a chance to continue that piece of the conversation, but I also want to be super mindful of lunch and the fact that we've been here already since 9:30 in the morning. Maybe we can start lunch at 12:30 and go until 1 if that's okay, and just give a couple minutes if anyone has any questions or anything they want to bring in. And if not, that's okay too. We can step away early, but um, any questions or anything that feels alive for you that you'd like to bring in. And you can also put stuff in the chat. And I can look into it and answer that way as well. Okay. I'm imagining like rumbling stomachs or something like that. Is that what's being said? Okay, got it. Okay. Received. Good. Okay. Well, with that, why don't we break for lunch? And let's plan to come back at 1. That gives us a little bit longer. And I'll look forward to seeing you then. We'll dive into diversity and we'll see if we can put it all together. So, and I'm going to stop recording, I should say.